Thank you very much indeed, and really good to see you all this morning. So, I was Minister of State for Care and Support, that was the title, between September 2012 and the general election last year, when my party was virtually annihilated. And now I'm back out of power and trying to find ways to influence things from the outside. But for that period of time, I had an opportunity to try to influence things in government. And there were two moments that stand out for me as moments which really shocked me. And I remember the first one, actually, I was with Christine, and we were at a conference in Wolverhampton at Molyneux. Were you there as well? Right, you were part of the problem, I guess. But I came, this was a conference organised by Black Mental Health. And I'd had some engagement with Matilda McCatram. Is she here? No. But I went along without really quite knowing what to expect. And the degree of anger, of frustration, and of disadvantage that I came across in that room really shocked me to the core. And I came away from that session feeling that something had to be done to address the anger and the sense of injustice of people from black and minority ethnic communities who were represented in that room. It was really shocking. And then there was one other occasion. I remember there was a debate in Parliament about mental health services, and I totally share the view of Christine. That there is an outrageous discrimination. It's not actually just a discrimination against black and minority ethnic people. Our son, incidentally, now 28, but at the age of 16, diagnosed with obsessive compulsive disorder. We were let down by the NHS. People with mental ill health do not get a fair deal. They do not get the same access to treatment as people with physical health problems. It's just that the situation is even worse if you happen to be from a BAME community. But I remember in that debate hearing the Labour MP, Stephen Reid, from Croydon North, I think it is, talk about the Olaseni Lewis case. And he challenged the government on what had happened and on the fact that the IPCC had dropped their investigation. And I was the minister responding, and I offered to meet with Olaseni's mother and father to talk to them about the case. And I met with them one evening, together with Stephen Reid, and to hear their anguish and their pain over what had happened, again, made me feel that there was an absolute moral imperative on all of us to try to do something about what is a wholly unacceptable situation. So I just wanted to refer to some of the facts first of all, and then say something about some of the steps that I've tried to take. So first of all, people from BAME groups in the UK are more likely to be diagnosed, and I use that term advisedly, with mental health problems. The Mental Health Foundation finds that African Caribbean people in the UK are more likely to be diagnosed with severe mental illness, 3 to 5 times more likely than any other group to be diagnosed and admitted to hospital for schizophrenia. And the Mental Health and Wellbeing Survey in England, Adult Psychiatric Morbidity Survey in 2014, found significantly higher rates of psychotic disorder in black men, 3.2%, compared with men from other ethnic groups, and for example, 0.3% compared to 3.2% for white men. And one of their conclusions was a need to increase mental health service resources in areas with a high proportion of black inhabitants. And the Mental Health 5-Year Forward View suggested or concluded that BAME communities are more likely to live in poorer or overcrowded conditions increasing the risk of developing mental health problems. And racism is likely to be another factor, according to the Mental Health Foundation. And on access to treatment, the Mental Health and Wellbeing Survey identified a pronounced demographic inequality related to ethnic group in access for treatment for common mental health disorders. Black adults have the lowest treatment rate, 6.2%, compared to white British people who have a treatment rate of 13.3%. Now, how on earth can we begin to justify that complete inequality of access to treatment? And people from minority ethnic groups are more likely to experience poorer outcomes from treatment and are more likely to disengage from services. And the Mental Health Foundation suggests that this may be because mainstream mental health services often fail, and I'm quoting here, to understand or provide services that are acceptable and accessible to these communities and that meet cultural needs. And the Mental Health Task Force, set up by NHS England, heard serious concerns from BAME communities about their experience of treatment, a loss of trust, they referred to, between professionals and communities. They wanted more support within communities rather than an over-reliance on inpatient care and containment. And the Mental Health Forward View stated, the 5-year Delivering Race Equality programme concluded in 2010, and they found that there was no improvement in 2010 in the experience of people from minority ethnic communities receiving mental health care. But the Forward View concluded that data since 2010 shows that little has changed since then. These inequalities must be prioritised for action, they concluded. Well, we need to see that action now. And on detention, the Joint Home Office and Department of Health review into Section 135 and 136, which I was one of the people to establish, found that black African men disproportionately overrepresented in Section 136 detentions. Use of force more likely. Black African and Caribbean men up to 6.6 times more likely to be admitted as inpatients or detained under the Mental Health Act. And the task force described this as a systemic failure. Also twice as likely to be detained in low secure services and to stay twice as long. More likely to enter mental health services via the courts or the police. And on restraint, and this is something I feel really strongly about, it seems to me that if force is endemic in a service, you cannot get good therapeutic care and recovery. And yet the Mind survey in 2013 found that it was endemic and found widespread and heavy use of face-down restraint, that type of restraint that Olaseni Lewis experienced before his death. Now, we, the Lib Dems, have repeated that Mind survey in the last few months, and we find an increase in the use of restraint around the country. That may be in part due to better recording of what happens, but there is no indication of a significant reduction and only a marginal reduction in the use of face-down restraint, and no data on the ethnicity of people who suffer restraint. And if you've experienced abuse in your life, the experience of restraint is particularly traumatic. And on tasers, at long last, we now have recording of data of ethnicity, and that is due to the pressure of Black Mental Health UK. Now, I acknowledge that there are brilliant people working in the police and in mental health services trying to change these facts that we witness in our country. And I'd written down here Christine Jones without knowing that she was going to be speaking just before me. But Dan Thorpe at the Metropolitan Police, also an inspiring, committed leader of trying to change the system. I'm working in the West Midlands, I'll come back to that in a moment, but Sean Russell, the senior police officer in the West Midlands, really committed to changing the way the system works. So I admire these people and many people in mental health services, but the system is still, in my view, too often rotten and needs to change. Now, let me just end by talking about some of the things that I've tried to do. First of all, as minister, well, after that experience in Wolverhampton, I decided that I had to engage with black mental health to understand what their concerns were and to seek to address those concerns in the things that I did. So we focused on the use of police cells under Section 136 and committed to and delivered a 50% reduction in the use of police cells over a 2-year period. We introduced the Crisis Care Concordat, which required every locality to get police and mental health services working together to get the system to work more effectively. Things like street triage, which we know dramatically reduces the use of Section 136 in the first place. And I think we have seen significant change as a result of that, but still a very long way to go. We issued new guidance on the use of restraint, which directly came as a result of that Mind survey that horrified me so much. I committed to issuing guidance. The guidance stated very clearly that we must end the use of face-down restraint. That's why I am so distressed that in the survey we've just undertaken, it shows very little reduction in the use of face-down restraint. And I brought a focus on what I regard as the outrageous practice of out-of-area placements, where people are often shunted hundreds of miles away from home in search of a bed. In doing this work, I should say, talked to Frank Bruno, someone I pay enormous tribute to, who has gone out and spoken about his experience. He talked to me about his experience when he was sectioned, of several police cars turning up outside his house, marked police cars, to take him off for treatment. Now, he said any neighbour looking would have assumed that I had committed a very serious crime. It's outrageous, that sort of behaviour. So in the Crisis Care Concordat, we committed to ending that practice. Now, since I was thrown out of office last year in Parliament, I've tried to continue to do things, working with black mental health. We tabled amendments to the Policing and Crime Bill to end the use of tasers in mental health settings. I don't think we can justify that, but the amendment so far has been rejected. At least now we are getting the data on use of tasers. The idea that tasers are a risk-free or safer option, I think, needs to be challenged. We tabled another amendment to ban the use of police cells under Section 136, so that people should be taken to a health setting rather than a criminal justice setting. Secondly, I got a debate on something that I did as a minister, introducing the first ever maximum waiting time standard. This is for early intervention in psychosis, a 2-week standard, so that we shift the emphasis, shift the resources from containment of people to early intervention, so that we stop that condition in its tracks. There is a wealth of evidence that if we act quickly, we can often rescue that person, stop that person having potentially a miserable life, a life on benefits, a life with difficult relationships. And yet what we found in an FOI survey this summer is that there has been completely flawed implementation of that new waiting time standard, and that around the country there's simply not been the investment in the treatment, in the evidence-based treatment, which we know works. We know that if you invest £1 in early intervention services, you get a return of £15 over a 10-year period. So why aren't they implementing this properly? It makes both moral and economic sense. And I got a debate on out-of-area placements and called on the government to end this practice. And then finally, I'm also chairing a commission on mental health for the combined authorities in the West Midlands. This brings together local authorities covering a population of about 4 million people. And we are focusing on how we can use public money, resources, more effectively to achieve better results for people. And the focus, it seems to be, needs to be much more on prevention of ill health and prevention of deterioration of health in the first place, whether we're talking about the whole community or particularly people from BAME communities. But I want us to focus in the actions that we propose in our Commission report, which is due out in the next couple of months. I want to focus on some specific areas that have a particular impact on people from black and minority ethnic communities. I want us to commit to ending, in the West Midlands, earlier than anywhere else, the use of out-of-area placements. It's a scandalous practice. We know it's identified and associated with a greater risk of suicide. We know that in some areas they have managed to end it, so we must all commit to ending it. Secondly, I want us to commit to a significant reduction in the use of restraint. We're going to apply for a grant from the NIHR, jointly with a professor called Joy Duxbury from the North West, to do a major programme across the northwest of England and the West Midlands aimed at substantially reducing the use of restraint. Third, I want us to explore how we can stop the increasing trend of detentions under the Mental Health Act, which has a disproportionate impact on these communities. Fourth, I want us to focus on making early intervention the standard practice so that we, as I say, shift resources from containment into primary care, so we stop people's health deteriorating in the first place. Fifth, I want us to look at how we can use crisis houses for the range of communities across the West Midlands to help us reduce the number of people who are admitted to inpatient care, often unnecessarily, and in a way that does not help their recovery. And then finally, we know that there are very many people who end up in the criminal justice system essentially because of their mental ill health. I regard it as a scandal of our time that there are so many people in our prisons who are there essentially because of their mental ill health or because they have a learning disability or autism. We have to do far better at stopping the flow of those people into the criminal justice system, identifying those people, giving them proper diagnosis and then treatment. When I was minister, I didn't mention this, but we rolled out a programme of liaison and diversion to identify people when they end up in a police station or in a court, so that they can be diagnosed, often for the first time, and get access to treatment. But we need to do more than that as well. In Milton Keynes, over the last 2 years, they have had a programme of substantially using something called the mental health treatment requirement. This is a sentencing option that has been available for many years in this country, but is virtually never used in most parts of the country. But it is to recognise that we should be addressing the underlying causes of offending behaviour rather than simply punishing people. And they are identifying significant numbers of people who have mental health problems. About 50% of the people on the court list in Milton Keynes, I was told, have some identifiable mental health problem. That is the scale of the link between mental ill health and offending behaviour, and so often we do nothing about it. So in Milton Keynes, they give people access to treatment with their agreement so that they have the chance to recover, to get help with their condition, to help them escape from their offending behaviour. We want to do the same in the West Midlands so that we can stop this dreadful flow of people and into the criminal justice system and give people the chance of a better life. For me, this is a moral imperative. There is also a dreadful economic waste for our country. So many people from these communities who could offer so much but are so badly let down by the system. There is an onus on all of us to do far better. Thank you very much indeed.